Welcome to another episode of Plastic Surgery Uncensored. I'm your host, Dr. Rady Rahban, and today we're going to tackle, I think, one of probably the ultimate, most important single issue in plastic surgery: your scar. In other words, the holy grail in plastic surgery is to do surgery, alter your nose, your face, your stomach, or whatever, and have essentially zero sequelae or any sign that anybody was there. And 90% of the sign is really the scar that is formed in order to do it. Now, there are a handful of surgeries that have minimal scars, rhinoplasty, liposuction, etc., that the scar isn't an issue. But for the overwhelming majority of plastic surgery, the scar is one of the major hurdles or obstacles for people in order to do it, right? So take, for example, a tummy tuck. Oh, I would do a tummy tuck in a heartbeat if it weren't for the ugly scar. Oh, breast lift, reduction. Oh, I do it in a heartbeat if it weren't for the ugly scar. Arm lift, thigh lift, and so on and so forth. So I have spoken about this subject 1 million times, and this will be 1,000,001. Why do I keep talking about it? Because it is the number one most important thing, and it is the most misunderstood, misled, lied about, deceptive aspect of plastic surgery. So I'm going to break it down for you today during this podcast. So if there was ever any doubt, it would be clear today. So number one thing you need to understand is your scar, the ultimate scar, let's just pick from a breast lift, comes down to three key elements. Number one, who you are, aka your genetics, your predisposition. Number two, what is done during surgery. Number three, what is done after surgery. Again, one, who are you? Two, what is done during surgery. Three, what is done after surgery. So who you are is who you are. Some people, they're lucky. Their bodies are predisposed to making thin, flat, white scars. By the way, notice there is no such thing as scarless. Scarless, meaning I cut you and it doesn't leave a scar, is for the future. I mean, that's like, placenta, da-da-da-da. That doesn't happen unless you do surgery in utero, okay? But for humanity, regular mammals, when I cut something, there'll be a scar. So what is our goal? For it to be a beautiful scar versus an ugly scar. For it to be essentially invisible versus unsightly. So who you are, your genetics, your predisposition, has a significant part to do with what you ultimately have. There are individuals, they are very rare, who develop keloids. They literally go and pierce their ear, single puncture, and poof, they make a cauliflower scar. They represent a tiny minority. That is not the common. Most people make a pretty decent scar, and some people are very lucky and they make a great scar genetically. An interesting issue that people don't really understand, that's actually counterintuitive, is one would think that a child heals better than an old man. And the reality is that it's actually the opposite. Why is that? Children make an immense amount of collagen. They make a robust, phenomenally thick and raised scar. From a biologic standpoint, that's a fantastic scar. Older patients don't generate nearly as much collagen. They don't have as much wound healing potential, so they make a thinner, flatter, shittier scar. From a cosmetic standpoint, that's amazing. So it's actually counterintuitive. But generally, and by and large, most people heal reasonably well. And for the most part, there's nothing you can do about it. In other words, it is whatever it is. Oh God, I wish I healed more like my sister. It doesn't matter, you're set. The most common thing I hear for patients who come for revision is, I had surgery, blah, 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 and my doctor said my terrible scar is because I heal this way. And while there might be some truth to that, overwhelming majority of it is a lie. What do I mean? I mean that, yes, if I, Dr. Rahban, close you, patient X, shitty, I do a terrible job, in other words, the part I'm about to go into, which is what I do during surgery, then you will make a shitty scar. I know that because in those patients that I do revisions in, come in, horrible scar, their surgeon before them told them, listen, there's nothing I can do, you just make shitty scars. I redo the scar change the way I do the scar that they had it done, and they heal beautifully. So what does that tell you? It tells you that it wasn't the patient. It was actually the closure. So then we shift from who the patient is, that is, what is your predisposition, to the bulk of your scar, which is what we do during surgery. So pay close attention, because this actually is the only or the biggest variable in the outcome of your scar. And this is what we can actually change based on who and how and what we get done. Number one, how did they open? In other words, when they made the initial cut, was it predominantly done with a blade, which is sharp and atraumatic, or did they go right through the skin and then use a cautery, which is electric cautery, and char the edges and get through the dermis? Why is that relevant? It's relevant because when you burn your way through the skin, you create a 1,000-degree heat inflammatory issue that later goes on to making thick scar. What do you think is going to happen when I burn the edges of your skin in 3 months, in 6 months? That tissue, that scar edge that comes together, is now inflamed. Well, how do you do it? I use a blade. I only use a blade, and I go through the whole thing with blade, and I get past the skin and into the fat, and only when I'm in the fat do I start using the cautery. Well, then why don't other doctors do it? Because when you go through the dermis with a blade, it bleeds like hell, and it's annoying. So what do doctors do? They go through the skin, and then before they go through the dermis, which bleeds, they cauterize the edges of it so it doesn't bleed and annoy them. Well, then how do I deal with the bleeding? I pre-inject you with epinephrine. So when I'm getting you ready for surgery, I put an epinephrine in all your incisions, wait 15 minutes, and then I cut. Then the bleeding is minimal, and I don't have to burn the edges of your skin. Next, when they're handling your tissue, the flap of your abdomen, your thigh, whatever, how do they handle it? And often, the edges of tissue are crushed. They're grabbing it with clamps or forceps, and they're squeezing the shit out of your tissue. What's inside that tissue is blood vessels and collagen and cells. And well, what do you think is going to happen if I sew together tissue that's atraumatized, hasn't been traumatized, versus if I sew together tissue that's been crushed or squeezed? Which do you think is going to heal better? You don't need to be a scientist to know that if you treat the tissue roughly, it won't heal as well. This is commonly seen with orthopedists. Orthopedists open up a wound, do their surgery, pull on the edges, crush it as they're putting in hardware, and then they'll call the plastic surgeon to come and close, and the wound heals like shit. Well, you crushed the shit out of the tissue that you're about to heal. So that's second. When they close it, how much tension is there? How tight is the wound? Remember, much of plastic surgery is cutting out tissue and sewing it back together. So if I make your abdominoplasty tummy tuck too tight, if I make your facelift too tight, the edges of the wound are constantly pulling apart. The human body is so brilliant, it knows that there's too much tension, and instead of unraveling and widening and getting open, it tells itself on a cellular level, make more collagen, put more cement into this so it doesn't fall apart. So you get a thicker scar when there's too much tension. Very commonly seen in a tummy tuck. Next, how much blood supply is going to the edge? Remember, much of plastic surgery is about cutting and lifting and pulling. When we lift, we go underneath the skin or tissue, and we're cutting blood supply. So if you were to examine the amount of blood supply to the edge of a wound, it would tell you how much nutrition is getting there. And sometimes surgeons are very aggressive about undermining, going underneath, that they get ischemic, which means they don't get enough blood supply, and then the tissue starts getting dark and necrotic and dies, and of course, what's going to happen to your scar? It's going to heal like garbage, and it's going to be thickened and raised. Those are very important. However, the single most important aspect of your final scar is, how is the incision closed? Did you guys all hear me? I'm going to repeat it for you. the single most important predictor of how your ultimate scar will look like in 2 years from now is how was the incision closed during surgery. So here we go. So the edges are far apart and someone has to put it back together. Well, what do you mean someone? I mean that 99% of surgeons, yes, plastic surgeons who do body contouring, breast, tummy, arms, thighs, etc., not nose jobs and eyelids, have someone who helps them close. All professionals who do a lot of major work have people who help them. Busy lawyers have paralegals who help them do research. Busy accountants have bookkeepers who do the numbers. Busy architects have draftsmen draw up plans. Busy dentists have hygienists do cleaning. Busy waiters have busboys who clean the tables. You see the pattern? So busy surgeons have someone help them close. Guaranteed. Okay, well, who is that person? You better ask your surgeon, not who's in the room, not who's helping you. Dr. So-and-so, aside from you, who is closing me? That's right. And 9 out of 10 times, it will be the tech. The tech? You mean the guy who answers them instruments? Yeah, the tech. Isn't that illegal? Yeah, it's illegal. In California, it's illegal for a tech to close. I guarantee you, if you walk around to every single OR in Beverly Hills and beyond, techs are closing tons of patients. If you're lucky, and I mean if you're lucky, your surgeon will close the right breast while your tech closes the left breast. But that's not usually the case, because if they're really busy and they're good, they're going to put a few key sutures, have a tech close both sides or 2 tech close while the surgeon is in the next room getting the next patient marked and ready to go. That is correct. You heard me right. The surgeon, the person you interviewed and paid, who has millions of followers and is famous for the card, that person is not closing your incision, which is the single most important thing in plastic surgery. So I, for 20 years, God as my witness, have closed every single incision in every single patient since the day I started practice. And I do body lifts, circumferential body lifts, thigh lifts, arm lifts, tummy tucks, breast reductions, everything. As a result, it takes me almost twice as long to do things because I'm the one sewing the right breast, and then I'm sewing the left breast, and then I'm sewing the abdomen, and so on and so forth. The next question is not who's closing, how are they closing? What do you mean? How many layers of suture? So we talked about tension. So you cut it open and you can bring it back together. When I close every layer of that incision independently. In other words, I close the deep scarpas or the deep layer. I close the superficial layer, the dermis, and then I close the skin. I do that individually. Suture one level, suture next level, suture next level. Then I put those sutures so close to each other. In other words, one here, one less than a centimeter, less than a centimeter, less than a centimeter, as opposed to one, an inch later, an inch later, an inch later. Why is all that closure necessary? I don't know if any of you have heard of Gulliver's Travels. So the idea is there's this huge giant, and next thing you know, he's been lifted and moved by a million Lilliputians. The Lilliputians are tiny little people. How the hell did they move the giant? Because millions of them moved him. The idea being is when you have tension and you distribute it by many areas, then no one area carries the tension. So if your goal is to have a beautiful scar, you need multiple layers very close together to decompress the incision. Not to mention you want it to be smooth rather than dipped in like a C-section. If a woman has a C-section, she'll tell you there's always a little pucker or a little dent in a scar. Why is it denting? It's denting because instead of closing all the layers and reinforcing the scar, the layers below haven't been closed or closed well, and the scar contracts and pushes inwards, and you get a little divot. So, how many layers? How far apart? The type of suture. So we have little tiny sutures and we have thick honking sutures. Well, obviously, as the layers are deep, you need thicker suture because they're deep and that's what's holding everything together. And as you go higher and higher, it should get smaller and smaller. Because the smaller the suture, the less inflammation it causes. So, how many layers, how far apart, what type of suture? Now, this part is crazy. In addition to closing every one myself, the last layer, which is the skin layer, can be closed a million ways. One way is with staples. One way is with glue, right? Kids, people go in the ER. My son lacerated his brow. I sewed my son up and I sewed him with permanent suture, which then had to be removed. When you go to an ER today, they're gonna bring it together, glue it, and call it a day. The last layer can be run with an absorbable suture that runs inside of the skin. Well, what do you do, Dr. Rahban, since you sound like you think you close best? The last layer, the skin, the last connection, I sew together every case with a suture called 6-0 nylon. And what's the story with 6-0 nylon? 6-0 nylon is a suture that I use during eyelid surgery. It's that fragile. It is the caliber of your hair, meaning it's like so thin. It's permanent, which means I have to put it in and 5 days later take it out. Why on earth would you do that? Well, I do it because it makes perfect reapproximation. And then since I take it out, there's no inflammation left behind. When you use an absorbable suture, well, where the hell do you think it goes? It absorbs, Dr. Rahban. How does it absorb? I don't know, through inflammation. Inflammation is the body's way of absorbing sutures. Now down deep, it's okay. But right under the skin surface, you don't want inflammation. So I actually put a permanent suture in, long enough for the edges to come together, but then take it out. So in the world of body surgery, that's bananas. The fact that I close myself, bananas. The fact that I put multiple levels of sutures individually so close together, bananas. The fact that I close with 6-0 nylon on a body lift or a thigh lift or a breast reduction or a breast lift, crazy bananas, and then it needs to be removed a week later. Do you guys think I enjoy closing? Like it's some hobby or fun or, woo, I can't wait to I hate closing. It's not fun. No one likes it. If it was fun, surgeons would do it. The reason surgeons don't do it, it's tedious. It's time consuming. I have a trigger finger in my right middle finger. I am 51 years old and I'm achy. I do it because it's the right thing to do. I do it because while my scars are not perfect and invisible, I think my scars are unarguably better than 90% of surgeons because of the extra time. Not because I'm some magician or I have some unique technique that only I invented. It's because I'm willing to take the time to do it and nobody else wants to do it because fuck, who the hell wants to stay in surgery when I can move on to another patient? So I want you all to listen to what I just said to you. Do not be fooled by anything else that's being told you other than closure. Educate yourself. Understand that no matter what, if your closure is shitty, your scar will be shitty. And there's no way of getting around that. The last part of your ultimate scar is the aftermath or the aftercare. So we said who you are, could be good, could be bad, can't be changed. How you're closed, which can absolutely be amazing or shitty, and then aftercare. Aftercare is less than 1% of the outcome. What are you talking about aftercare? Lasers, scar cream, tapes, this, that, snake oil, this sand from the desert of Sahara, blah, 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 blah. All that is garbage. Surgeons love to sell you on aftercare. So what they say is, oh, when you do a tummy tuck with me, we have a scar management protocol or something that we do. That's just nonsense. Why don't you just close this incision well, take the time, and then I don't need all this Mickey Mouse crap. If lasers and creams and lotions and all this nonsense worked, I would simply have my tech close and laser the shit out of you afterwards. Why wouldn't I do that? It doesn't do squat. Once you have a shitty scar, all that stuff isn't going to do nothing. It sure as hell. And the last thing you want to do is inject it with steroid or something crazy like that. At the end of the day, there's no shortcut to it. It comes down to time, like tapestry or a beautiful Persian rug or some needlework or some painting that took months, or chiseling down a piece of stone into a gorgeous statue. All things that are worth it take time. There is no shortcuts, and I assure you, if there was, I would have figured it out, because I'm no hero. If I can get you a great outcome and do half the work, trust me, I am all for it. So, let there be no confusion. The number one most important thing in plastic surgery is, what will my scars look like? It is down to 3 key elements: who you are, what's done during surgery, and what you do afterwards. Who you are is who you are, you can't change it. What's done during surgery is all about your surgeon and his or her willingness to take the time and do something well. And aftermath makes almost no difference. So hopefully that's clear. And you can take that wherever you go. Oh, I'm about to have a C-section. Oh, I'm about to have my gallbladder removed. Oh, it doesn't matter what the scar is. A scar is a scar is a scar. At any rate, that's my spiel. I've said it 1,000 times on Instagram, TikTok, YouTube, podcasts in the past, and I'll just keep saying it over and over again, because obviously it's not very popular, because then surgeons are like, oh shit, he's telling everybody the truth. Now I have to operate and do the extra work. And to be honest with you, I don't want to. Anyways, guys, that's a wrap. As always, I'm your host, Dr. Rady Rahban. I hope you enjoyed that podcast. If there's 2 things I can ask you, I would be grateful. One is, if you enjoy the show, you found it interesting, go write a review, write something nice right now, right this second. Literally, just as you're listening to this podcast, pull up the write a review part and write something nice. Everyone here is working hard so you have a cool episode once a week. And the other is, forward this episode. Forward all our episodes to people you love, your friends, your family, because you think they'll tell you if they're about to have plastic surgery, like, oh, let me tell you something. You don't know they're going to do plastic surgery till it's too late. And at that point, then you're going to wish you had sent them the information, okay? So that's a wrap. As always, I'm your host, Dr. Rady Rahban, and I look forward to yet another episode of Plastic Surgery Uncensored.